Good evening, everyone. Welcome to our webinar tonight. Thank you for joining us. Tonight's webinar is a very interesting topic. It's called Women in IR, What We Can Learn from Our European Colleagues. I'm pleased to introduce our speaker tonight, Dr. Bella Huasen. Dr. Huasen is a board-certified clinical radiologist with a subspecialty interest in vascular and interventional radiology at the Royal Preston Hospital in the UK. She finished her diagnostic general radiology residency at Royal Preston Hospital, followed by a fellowship in interventional radiology in the Auckland City Hospital in Auckland, New Zealand. She currently is an attending at the Royal Preston Hospital. And just to clarify some terminology here, I learned just this past summer, I guess this past year, that the in the UK, British medical system, the attendings are actually called consultants, and the residents are called registrars. So that way we don't get everyone confused. All right, so without further ado, I'll hand the talk over to Dr. Huasen. Oh, sorry, one thing to add. During the presentation, if you guys have any questions, make sure to type them in the questions box, and we'll wait till the end of the presentation to address them. Also, this recording, as all of our webinars, are recorded and will be made available on YouTube at a later time. All right, thank you. Okay, Bella, you can go ahead and start presenting.
My IT skills are terrible, so you have to bear with me. The title is a little bit different to necessarily what I'm going to go through, but we'll just see how it goes. A little bit is about IR in general, and some of the other stuff is the trainee perspective of what they think IR is. So just for those of you who are not familiar with the UK and where Preston is, don't worry. I'd say that most British people don't know where Preston is, but it's got a direct train link from London, so you can get there within 2 hours. So a little bit about me. I did most of my training in the UK. I started off at university medical school between Manchester and Edinburgh, and I went into surgery. At the time, it was very and then from there on, I went into IR through the radiology training scheme. And in the UK, unfortunately, it still remains that if you want to do IR, you still have to go through general radiology and still do the exams. And over those 6 years, and in the 7th year, I did multiple observerships and attachments. These are not mandatory in our training scheme. This is more of me trying to figure certain aspects of my training that I felt wasn't sufficient, or certain things that I wanted to understand a bit more that I thought maybe other colleagues around the world would know a bit better about. In terms of my IR interests, I would say that I'm heavily endovascular, which means I'm really heavily into blood vessels, and mostly what other countries would label as vascular surgery. I'm quite lucky in my sense that this is still all under IR. So why did I go from surgery to IR? It all started with Bob. I met Bob in Zurich, where I was doing microvascular training. And unfortunately, Bob was suffering from a lot of clots. And Bob and many of his relatives I was doing. And what I noticed was a neuro IR fellow got a little tiny catheter and sucked the clot out. And I was like, whoa, what is this? And he's like, oh, this is IR. I'm doing IR training. And basically, that's how it all started. And these are just some examples of the clots that we took out, whether it's through a catheter from an arm or from a person's brain. Now, going to the more interesting topic with IR, that females are not the most common people in IR. Well, I'd say it's not just IR, it's endovascular in general, whether it's cardiology, vascular surgery, or IR. There aren't many of them, despite that certainly in Europe, 60% of medical students are female. we've been very lucky that we have Anne-Marie Belli down in London, and she's been looking at this very closely. And one of the striking things that she mentions that only 10% of IR consultants in the UK are actually female. I'd argue that it's probably realistically less than that, because the majority of them are seniors who are now retiring. So I'd say within this year, it'll probably be about 7%, which is a little scary if you think about it. So look into medical students, and particularly female medical students, to try and understand why they would not go into IR, or if they've ever heard of IR, and would they be interested into going into IR. I started off by looking at UK medical students, and since I've been in New Zealand, I've looked at the Auckland students as well. So you've got a rough age between 18 to 27, and it's been last year and this year. And hopefully we're going to get to the countries to join this year, Germany and Poland, so we'll have better data of understanding. It's really interesting that a lot of them have heard of radiology, but not IR and such. And they have heard of vascular surgery. So to me, it's a little bit surprising, because you think if you know a bit about vascular surgery, then it should really fall into place that you may have heard about IR. But you'll see from the data that we've collected here, it's much less than that. It was a little bit upsetting when talking to them that most of them didn't want a career in IR, which was a bit sad, because I'm there saying, why don't you want to be me? And I think it comes down to, has anybody really had much teaching or lectures or any insight into IR? And as you can see, that the majority, a good 38 of them, have had no idea. And therefore, how can you expect somebody to want to go into something when they don't even know anything about it? And I think this has come from you guys actually in the US, the road to happiness. It's something that we don't really have in the UK, but it seems to be adapting quite quickly. As you can see, IR is not part of that category. It's just radiology, ophthalmology, anesthetics, and dermatology. IR is supposedly not a way to live a happy life as a doctor, which is not true. So we looked at those students again, and we went through what they thought an IR career was like and what would have them consider it as a career. I don't know if in the US and other parts of the world if you have something called run-through posts, but in the UK we have subspecialties. Once you get in, you're kind of guaranteed that training until you become a consultant, the boss. And radiology is one of them, but there's no such thing as IR, so you'd have to go through radiology to get into IR, but it's still considered a run-through post. And I think the majority of people, certainly in Europe, seem to like the idea of run-through posts and not having to apply and reapply. Without saying, good pay is an important thing for most people, but again, it's a surprising thing that it's not the most important thing, especially for these female students. Female role models and having females in high positions who I quote are normal was actually more of a significant thing to most of these students, whether they were from the UK or Auckland, and also from the new data that I'm getting from Germany. And that's quite striking to say that one of the things that will influence you is whether there is a female out that represents this profession in a way that these young medical students see appropriate. And then the usual help with the exposure, and I think that goes with any career. Also media.
Sorry, I'm going to stop you. Well, I'm going to stop you for just a little bit. I think there's a lot of like noise coming through, like helicopter noise and wind noises. I don't know, is there, like, are you outside presenting right now? Bella?
If I do it directly from the laptop, would that be of help?
Yeah, if there's a way to like speak directly to the laptop, like maybe through a microphone, or just speak louder, because I think the
Let me just try to turn off the Bluetooth and see if that's any better.
okay.
Is that better now? Or
Yeah,
is there still a lot of noise?
I think this sounds a little bit better because earlier I think some of the wind is kind of breaking into your voice once in a while. But yeah, I think this is better.
Okay, sorry about that. Let's try this. Oh, let's go back. Okay. Yeah, but do interrupt me if you find that there's any issues because I can't hear you, so I'm assuming that all is well. So yeah, sorry, I was just saying that obviously the media does play an important part, and I think that's not necessarily for just medical students, but also for those that are about to enter medicine and the idea of what they assume the different subspecialties are. So these are the common things that came across from most of the female medical students, and they said that of the IR females that they have seen or what they perceive is that they have weird bodies, they're hunched back and whatever. And that was quite scary because I'm standing there having to do this thing and I'm like, oh my God, am I gonna like have issues after this interview? But I'd say most of the IRs and most female doctors in general, whatever their subspecialty is, are pretty fit and well. I don't think there is any issues in terms of your figure if you did do IR. They said that if you went into IR, you become serious, especially if you're a female. You lose your fun and your enthusiasm. And I say that's probably as far as you can get from the truth. Most of the female IRs are crazy, probably more fun crazy than anything else. There's a lot of insinuation that they don't have family life, that the majority are living with cats. I'm not sure why cats. I mean, I think most normal people have cats anyway. But that's not true. I mean, I still have a good balance of life, and I've got, 3 godchildren. So I think you can balance things. You're surrounded by mostly men, whether it's vascular surgeons or other male IRs. And this is really actually a really wrong thing to think of because most of the radiographers and nursing staff are actually females, and that's who you work with most of the time. It's not other male doctors. It's heavily actually female in the workforce. And it means that they understand you and you get like pink little cute things made for you on a regular basis. They do little outside work. I'm not sure where they got that from. I think that most of medicine and those that are dedicated, yes, you would have to invest a lot of time and effort. But I would say a lot of the IRs are nut jobs. A lot of them sail, ski, and do a lot of crazy stuff. So out of the profession, I mean, I managed to get a lot done being an IR than when I was a surgeon. So the reality is that most of these female medical students, and I'm not focusing just on female, I also did interview male students, is that they didn't realize what IR was about and what IR procedures were involving and what IRs were doing on a day-to-day basis. And therefore, all these assumptions of that IR are nobodies, they hardly do anything, they're just kind of doormats to surgeons, is really sad because they're missing out on a lot of exciting new technology. So I'll see if this video works, but I'm sure that a lot of you are super duper at CT imaging, but you can see that there's a lot of clot in this young patient with a PE. Now, you have 2 ways of managing this. You could essentially put them on a long time warfarin. And then if you put yourself in that situation, you're a young, healthy person, and you've got your life ahead of you, the last thing is you want to be on warfarin. Whereas IR is kind of a profession where we can go in and directly treat and avoid surgery and avoid drugs. So this is my colleague actually going in there and sucking all that clot out. And that's amazing. I've just shown you the CT. It's almost mostly occluded. And in that image, the clot is kind of plugging most of the pulmonary artery flow. And on the next image, you can see that it's completely resolved. All that clot has been removed. This patient does not need to go on warfarin. You get loads of toys and exciting things, loads of discoveries made on a regular basis. This is an ultrasound image with using the Taratola device inside the vein of the fistula. And I'm just doing the ultrasound, trying to show you the images of inside the vein. It's almost like a whisk mechanism. This was invented by an IR doctor. So not only in IR can you do procedures that save lives, because you're constantly inventing, a normal person is able to invent stuff and kind of make history, if that makes sense. You can't really do that in most other professions. It takes years and years to move on. For example, my background, plastic surgery, a lot of things haven't actually developed since the World War. It's still the same flap techniques since my granddad was doing them. And I'm going to just show you a few bits and pieces about IR. And I mean, it's extensive. I could be here till tomorrow, and I don't want to bore you to death. But this image is trying to show you a lower limb. It's an elderly patient who has AF, and he's clotted off his arterial supply to his leg. And the middle picture, I've just shoved in a catheter. Some of you, if you know it, the penumbra indigo system. And it basically aspirates, it just sucks clot out. And we were able to resolve the blood flow back into the leg by removing the clot. So again, this is a patient that doesn't need anything else doing. He went home on the same day. You can get into fancy stuff. I mean, this is quite an extensive case. It's a patient that's got flow to his aorta, but as soon as it reaches the bifurcation, you're only seeing a little bit of flow going into his left common iliac, and that's about it. So we were able to reconstruct all of his iliacs going all the way into his common femorals and save him an operation. And this is a technique by removing clot, molding the vessel, stenting, etc. But it just meant that there's no operation involved. And yet again, this is a patient that went home on the same day. You've got new toys. Usually the US, you get toys before us. But this is one of the devices I used in this case where the toy is about to come to you guys, and it's called the Rotarex. And it's kind of a thing that sucks clot and a bit of calcium and heavy stuff. And I used it successfully in that case. This is probably the thing that I love the most, declotting fistulas. Fistula patients are very important to me because a lot of them are still leading normal lives, and this is their lifeline. They rely heavily on their fistula. So the ability of their fistula to work, to allow them to have an efficient dialysis is so important. So for me, I'm kind of called a glorified plumber. I kind of declot their fistulas on a regular basis and keep that mechanism working for them until either they get a successful transplant, or if they're not a candidate for that, at least maintain a good quality of life while they're with us. And the other thing to bear in mind in IR is that we don't just deal with adults, we deal with absolutely all walks of life. And this includes fetuses. There's a lot of technology and a lot of work being done to fetuses before they're even born, before they're even formed. And then pediatrics. For those of you who have a keen interest, we do quite a lot in IR, and you do get some culprits who are regular visitors. On the little man here, they've drawn a beard. He's one of our regular customers while he's having treatment, and he's always unhappy. He's just like a grumpy little old man. And Ellie on the other side is a happy little girl. The consent has been obtained from parents to have these images, so don't be alarmed to why I've stuck them on. The parents are actually either clinicians working with me or in the industry, so they understand the importance of showing you the involvement that we have with various aspects of the community. Again, the quicker you can treat them, the quicker they can go home and lead a normal life. And this is a daily, regular basis that patients are so grateful. I get fed a lot and it's unbelievable. It's probably more than what I used to get when I was in surgery. So what I want to conclude in essence is that we really do have to have a way of showing the public, showing medical students, and even trainees what IR involves, because I think that it's such a wide specialty that there is something for everyone. It's not like surgery where you may need to be a particular type of personality or a particular type of skill to fit in. I think IR is one of those that fits almost all walks of life. You just need to discover what it is that you're good at or what you enjoy and what you can adapt and fit your life around. And I personally feel that it should start early on, whether it's through universities or even school level, and somehow tap into the media as well to show a healthy picture of what it is that we do. And that can be done through various ways, and I suppose from collaboration between many IR communities, we can come up with ways to do that. But the most important part for me, both as a trainee and now as a consultant, I'd say the importance of being kind to each other. Training and medicine in general can be a very hostile environment. It can be very competitive, and people can get caught up in this circle, and I think it's unnecessary. There is a place for everybody. If you genuinely want to help people, there's a place for you. So try not to make life harder for yourself or others around you, and definitely collaborate and work together. It's a key. And I'd say in most successful departments that I've been in, the key to their success hasn't been because they've got geniuses in their department. It's because they've developed the ability to know how to work with each other. And this is an interesting thing for those of you who may recognize these characters. I don't know if any of you are anime fans or cartoon fans, but this is Studio Ghibli, and it's very interesting and important that he makes a huge thing about his female characters, that they are actually the heroes of most of his films, and they are role models. They do interact and work with other characters, whether they're male or female, but essentially they are the ones who go and do the work. And I think this is essentially how females should view IR. You've got your role there as a female, and you will work together with other colleagues, but you don't need that kind of hero to get you into it. You can be that hero yourself. But again, it's not about feminists that, you know, this is just women and women need to take over IR. I think it's a collaborative work between males and females, and the same support that I'm offering females, I definitely will offer that to male trainees and male medical doctors too. But it's just that culturally it's been heavily male dominated, and I think that might have put off a lot of the female doctors, and it's kind of our role not to miss out on good quality doctors because of misconceptions. Well, thank you very much for your time. I'm sorry that a lot of my stuff is about clot because that's my interest. That's my email, so if any of you have any questions, or if you ever want to get in touch with me, even if it's not necessarily about this talk, but if you want to talk about fellowships, experiences elsewhere, I'm happy to help you because I've got many links, and I feel that sometimes people don't always give the honest advice and opinion about a certain training scheme or a certain fellowship, and I think that's unfair because you shouldn't really waste your time in the wrong place or the wrong setting. And that's a little picture of a place that's not far from the hospital here in Auckland, so if you ever visit in New Zealand, do drop by. Thank you.
Thank you, Bella. That was a really interesting talk. We had so we'll go ahead and open up the panel for questioning. If you guys have any questions, just go ahead and type them in. We had Alexandra make a comment. She said, "Thank you for emphasizing kindness to each other. It is the most important aspect of successful progression through residency."
I definitely agree. And, you know, it's really sad that when we're training, especially in the UK, now we're coming more and more out with it, that there's been a lot of bullying going on. There's been a lot of pressure on the juniors, and you kind of somehow you're expected to just take it and proceed and serve your sentence, if you like. But I think this is really unnecessary and it's got to stop. And one of the ways we can stop it is by stopping ourselves and starting with ourselves. And if each one of us was to do it, trust me, before you know it, it'll become a culture that not, you know, this is no longer acceptable. You have to be kind. We will never be able to fully get on with each other completely, because it's just like you would at home, that you'll have a sibling that you don't necessarily get along with, or an aunt who's crazy, or, you know, that grandma that never shuts up. The same applies to work, but you'll always find a way of how to come around it or work better with those individuals. And I think that's really, really important, and just being able to support each other.
All right, thanks, Bella. Does anyone else have any questions?
Hi, Bella. This is Jill. Yeah, I'm the chair for Women in IR. I'd like to thank everyone from our committee for being here tonight, and also really appreciate Bella to put together the presentation and also give us the perspective. You know, as someone who's practicing IR in Europe. But I want to ask you, so how's the training system like in the UK? And as you mentioned earlier, if people are interested in doing a fellowship like in the UK or in the New Zealand, what would be the process? Or even just for a short exchange program, is there anything like that that people can do?
Yeah, this is a good question. Now, if I just briefly tell you about the UK, most people go into IR through radiology. It's a 5-year training program where you would do the first 3 years heavily general radiology so that you complete your exams. And then essentially 4th year, so your 4th and 5th year, you can focus more on IR. So maybe out of the 5 days, 3 will be to IR and 2 will be service commitment. And then you are now in the UK expected to do a 6th year. And that could be in the same training program you're in, which most of them do offer, or it can be in another training scheme within the UK. But essentially, go and apply for a consultant job, an attendee position, or, you know, a senior person position, or you can go abroad and do a fellowship or research or whatever, and then come back and apply for a consultant post. That's entirely up to the individual. I'd say the majority of people tend to go on into a consultant job after their 6th year. For myself, there are plenty of fellowships.
Hey, but I think your voice is breaking up a little bit the last few seconds. Can you repeat that answer?
Society. Some are small kind of rotations, like you may need to arrange yourself. When it comes to the Oakland post that I am currently doing, it's under the title of fellowship. So you kind of apply through the Auckland City Hospital IR team, and they get the process going. I think it's important to clarify what it is you want to achieve and what you want to learn, and tailor that to the fellowship that's available. What can be misleading about fellowships is that you can go into a fellowship because of a certain person's title, and actually when you get there you find that your needs are not necessarily met in this place, and you could potentially, I don't like to use the word waste because you're always continuously learning, but you may waste a bit of that valuable time doing something that's not necessarily what you were hoping to achieve. So it's very important to do the research well before you get into it. In particular, speaking to current and old fellows. so that you get an idea of what's actually going on in that moment in time, and if that's what you're after. If I give an example, if you want to do IR oncology, because the dream job that you aim to have in the end is an IR oncology center, then you may not want to come to my hospital because we're heavily vascular. So even though you may learn these essentials of access, embolization, and trauma, you will not get the full experience of TASE and CERT, which you might be expected to do in an IR oncology center, and vice versa. If you are in a center or a job that you hope to be in and you are expected to offer EVAR or fenestrated work, and you do a fellowship, for example, in the UK, the Christie Hospital, then you will not get that because it's essentially more heavily towards oncology. But none of these fellowships will ever be a waste of time because there's always so much to learn, whether it's even just basic self-development. But for me personally, because time is precious, I think always do your research thoroughly. Try and get the truth behind each fellowship, because IR, you're like gold dust. Everybody wants you. You're a limited specialty wherever you go in the world, and there's so much service work to be done. So, you know, everybody wants an IR fellow, everybody wants an IR trainee, and most people do want IR consultants. So actually, the way I see it, the world is your oyster, and you should try and find what suits you and what meets your needs.
Great, thank you so much, Bella. Any other questions?
All right, so if last call, if we don't have any questions, then we'll end the presentation here. And again, the entire presentation is recorded, and we'll be putting it on YouTube at a later time. Thanks again to Bella for preparing this presentation. It was really interesting. All right.
Thank you, guys, and thank you for your time.
All right, thank you, Bella.
Yeah, thank you, Bella, so much for being here today. I know you will also have lots of time difference from us too, so thanks.
Thank you.